So I will start with the first question for each of our expert doctors. Briefly describe, and we'll start with you, Dr. Lofters, your area of expertise, which was indicated in your bio, but what really motivated you to get into the medical field?
Thank you for the question, and very happy to be here, and thank you for inviting me. So I got into medicine really because my father was a doctor. So, the very typical story of wanting to follow the example of the person in front of me. I will say my father made it clear to both my brother and I, my brother's also a physician, that we shouldn't do medicine just because he's doing it, because it's a hard profession. It's very challenging. There's lots of stressors, but we both ended up going into medicine. And when I actually went to medical school in Baltimore at the University of Maryland. And Baltimore is a very unique city. It is very racially segregated. It's about 70% Black. And I saw right in front of me a lot of the disparities that we know about in healthcare. They were here in Canada, they tend to be a little bit more hidden, but they're very obvious in the US. And I really developed a passion for thinking about ways that I could address those disparities, which is why I ended up going into research. I think as a clinician, you get to have that one-on-one interaction with an individual, but with research, you get to potentially impact large numbers of people with a single project. So I chose to go into family medicine. I loved the idea of having a long and continuous relationship with people. But when it came to, one of the things I loved about family medicine was the idea of prevention, so that we can prevent a disease before it starts through things like lifestyle, through things like addressing risk factors, and through things like screening, so cancer screening. So I really developed a passion for this idea of prevention. Ended up falling into the world of cancer screening just because of that idea, and really focusing on health disparities because of my experiences in the personal aspect.
And thank you for those insights. So now over to you, Dr. Cavelli. Just please help us understand what motivated you to go into the medical field.
No, again, thank you for sign on. Yes. Okay. So thank you for having me here and inviting me to be part of this. My story is very different than Dr. Lofters. I actually didn't know anybody in medicine and didn't grow up around anybody in medicine. I came from a lower socioeconomic status, and I'm very thankful, and I just happened to be very gifted in math and science. And so I went through that in school and thought I wanted to be an actress. And was not very good at that. I realized I could not make a career out of it. And so just continued to pursue math and science because those were the gifts that I had been given. And in doing so in university, I met a lot of students who wanted to go into medical school and didn't really know what it was all about. And I took one of those tests that say what you would be good at. And they're like, oh, you're a great people person and good in science, and you should be a doctor. And I kind of laughed at it. But I did all the steps. And again, I was very thankful that I did get into medical school. And I went into it knowing I was interested in women's health. And I thought I wanted to be an obstetrician and gynecologist. And I realized I did not like delivering babies, which is a big 50% of the job. And I did a surgical rotation thinking that I just wanted to get it done and over with, and I would never do it ever again in my life. And I loved it. And I loved being part of the team. And I loved that I could go in and help somebody. Unfortunately, when they were already in the disease state, so I do very little prevention, but that I could go in and solve a problem and try and get a patient, whether it be an acute emergency or cancer care, onto the next step in their life. And so really medicine and surgery chose me. I didn't choose it. During my surgical residency, again, that interest in women's health really combined with surgery in the realm of breast cancer and breast cancer care. And that's how I pursued that as my clinical career. But much like Dr. Lofters described, I love that one-on-one and being able to help the patient in front of you. But how do we change care beyond that patient in front of us? And more importantly, how do we move care forward? So we've seen great strides in the care that we're able to provide to patients, but that's not enough, right? We're not there yet. And that's where research comes in. For me, I wanted to do what's known as qualitative research. So that's really understanding the whys and hows of the problem. And I did my PhD exploring breast cancer treatment. But once I came on as staff, I knew that I was, as I'd always been, I was more interested in equity and care and just seeing the injustices that exist internationally, but even right at home. How can I use the tools that I had gained to try and be a part of that? And so really now I focus on health equity in cancer care.
Oh, thank you so much for sharing that. And for you, Dr. Daniel, what motivated you to pursue the medical field?
So I think most people know my story, but my motivation was unfortunately, well, I guess I should say, like Andrea, actually, I was really good at math and physics in high school. But no one ever suggested I become an engineer, which would have been the logical recommendation. They all said, oh, you should be a doctor. And I wasn't even taking biology at the time. So, but again, I came from a low income family where no one had gone to university. There was very few people to guide and mentor me. So I got accepted to Queen's. My parents had saved every nickel and dime so that they could pay for my tuition for the first year. They hadn't saved a penny for second, third, or fourth year. But because I think they and my entire community and my family knew that I was a unicorn in the family and a unicorn in the neighborhood. So they were all behind me and praying for me. And then, so I was very much bound for med school because that's what my family wanted. That's what everyone said I should do. But then in my last year of undergrad, my next door neighbor in Barbados died of breast cancer. And then my mom was diagnosed with ovarian cancer about a month after that. And then my mom died of ovarian cancer 4 days before convocation. So kind of like Andrea, I didn't necessarily choose cancer research. Cancer research chose me. And I became, that's when I decided I wanted to do cancer research and wasn't that keen on being a physician per se, because I felt like the physicians, in my 22-year-old mind, the physicians had failed my mom and my neighbor. And I felt that they died because there weren't enough treatments and therapies to prolong their life. So I wanted to do research, which I felt would contribute to that increasing survival for cancer patients, not necessarily women. I wasn't focused on women per se, just survival. So yeah, so that's how I went down the road of cancer research.
And thank you to each of you for the work you're doing. So important. So the next question is about, I don't know, my mic is, can you still hear me? Yeah, it's still red. Okay, can you comment on the myths about clinical research? Or as I said, there is a distrust with some communities of color, especially for the health system. And so because of these myths, and maybe elaborate what they may be, this may cause people from marginalized communities to be hesitant to participate in the clinical trials and the research. And this can be for any of the panelists, just to comment on the myth. Yeah, he's gonna fix it. He's gonna fix it. Okay, we can share.
It's just for those online. I'm going to say that again. So can you comment on the myths about clinical research that might cause people from marginalized communities to be hesitant to participate in the clinical trials that we know is very important for research?
So I'm happy to start. I'm sure we all have thoughts on this. So I think it's important to note that some of the myths today come from truths in the past. So there were plenty of times documented in the past where there were very unethical studies that were conducted in the name of research. So I think one of the big obvious ones is the Tuskegee syphilis experiments. There was Henrietta Lacks, whose cervical cancer cells were taken from her, and lots of research and profit was done without any acknowledgement to her family. The father of gynecology was actually a man who performed surgeries on enslaved women with no anesthesia. So there's all of these examples in history that were truths when research happened, and it was not done to benefit communities of color. It was done exploiting and often torturing, quite frankly, communities of color. And then even to this day, we see examples of research that's done where people will come into a community, they will do a research study, and then they'll swoop out and they're gone, and they've got their publications and their name, in lights, but the community doesn't see any benefit. So I think that there have been very real and are to this day still very real examples where researchers exploit communities of color in Canada. So I think I also want to note that that's happened very much with Indigenous communities as well in Canada. But the flip side of that is that often the great advances that come in healthcare, cancer care in particular, come directly from research. So, Dr. Daniel's lab, as an example, chemotherapy treatments, surgical advances come from research. And when we don't participate in that research, I think there's two big things that happen. One is that the research itself suffers because the people who participate are not as diverse as they could be. So we don't know for sure if those results really apply to everyone more broadly. And then we just don't get the direct benefits. So I can give you one personal example. My father had multiple myeloma, which is a kind of blood cancer. He passed away in 2021. But he lived an extra, I would say, solid 3 years because of participating in a clinical trial. And he had access to a medication that was otherwise 6 figures, incredibly expensive, no way to access it otherwise. But he accessed it through this trial. It worked extremely well. And he literally had 3 more years of life. So I think when we don't participate in research studies, we have to think that we're missing out on opportunities like that one.
That's really important. Does anyone else want to comment on this question?
I would echo what Dr. Lofter
Okay.
said. Essentially, I agree wholeheartedly. What we consider myths today are absolutely rooted in truths. The hesitancy in the community is not without reason.
Right.
The question is, as Dr. Lofter says, there's absolutely benefits that can be derived. But how do we get over that hesitancy?
Mhm.
How do we get people to want to engage in trials when there's been so much distrust, but with reason?
Yes.
And that's one of the challenges as researchers that we face. Quite honestly, some of the pharmaceutical companies have reached out to me to try and ask this question. How do we get, it's around breast cancer, so women, I was like, how do we get women of color to be included in our drug trials so that we know that these results are applicable to this community? Like, how do we make sure the medications that we're giving or the advances that we're doing are truly applicable to the people that we're giving them to? Because what happens right now is whoever's in the study, we get these results, but then we apply them uniformly across everybody. And that might not be what we need to do. And so it was just a brainstorming session. I told them I didn't have the answer, quite honestly, and that a lot of work needs to be done. But it was really interesting to see the drug companies at least recognizing this and wanting to take the steps. And really, I said it needs to happen at a community level. You need to engage these communities. You can't just put out a advertisement and say, we want you involved.
And it's also about relationship building. Did you want to add?
Yeah, I just want to add to that because we were talking about this just before while we were waiting, is that we also need more physicians and surgeons and researchers that are from our community to help bridge the gap between what we're doing and the community. So we were just talking about this, how many Black breast oncologists and surgeons are there in Canada? And they're not many. How many Black, like we were just, there are not many Black cancer biologists like me in Canada. To my knowledge, there's 3 or 4 of us in the whole of Canada. Like we need more students to consider these professions and to pursue them, because until that happens, and we can't wait 30 years. Right. And so, because some people were saying we shouldn't invest money, because I was lobbying to invest money now into the kids in high school so that we can start giving them scholarships and reward to get them to that end point. But our society loves quick fixes, and the idea of waiting 30 years for this cohort of young people to get that point is not something anyone wants to invest in. And I think we all need to start advocating and pointing out that you have to invest in them now, because it will take 30 years before any of them becomes a professor or a doctor or a surgeon. And so if we don't do that, it's like we're going to be having the same discussion in 30 years. There will not be enough Black scientists or clinicians or surgeons in Canada. So
yeah, that's a huge gap. And just a follow-up question to the racial disparities and gaps when it comes to cancer diagnosis. There was a little mention of the research gaps, but gaps in treatment. Like, what does this look like in terms of the disparities as it pertains to people of African ancestry? Like, how wide is the gap, basically, when it comes to the research, the diagnosis and treatment?
I can speak to the research. As I said, I'm doing what I can, but I'm just one person and I'm only looking at triple negative breast cancer. I don't know if anyone's in Canada even looking at prostate cancer in Black men, which is also a real health issue in the Black community. There's, as I said, one or two other Black cancer biologists that I'm aware of studying breast cancer at that molecular genetic level, but that's not enough. Like it's real. So there's a huge gap in what's known and what's not known. And again, it goes back to the trust. Like we just don't have the data. And then it perpetuates because of the way our research system is modeled. You need evidence, you need stats. So if we're not collecting race or ethnic based data, then we don't have that evidence or stats. And it's really hard to convince the government or any research panel to give you money to study this. So it becomes this kind of chicken and egg situation where they want evidence and stats, but we don't have it. But we know anecdotally, so how do we move forward? So maybe Aisha or Andrea have better solutions.
No, not a better solution, but I would echo it. It is very circular that in Canada, we don't collect race-based data. And I think there's also an issue around trust with the idea of collecting data, because why are you asking me that question? And what are you going to do with the information, which are very valid questions. But because we don't have those race-based data, I know for all three of us, we often will speak about US statistics. The US is our closest neighbor, but it's not the same. Like we don't have the same healthcare system, the same funding. Our Black community looks very different than the US Black community. Ours is much more diverse as far as countries of origin and immigrant status, et cetera. But we don't have the race-based data here in Canada. We often will know from clinical experience and personal experience that there are disparities, but it's true that the very first thing that funders and policymakers want to know is, well, where's the evidence? And if you don't have the data, then they're like, well, there's no problem. So we're not going to do anything about it. So I think there's been much more of a push in recent years to start to collect those type of race-based data. And now different hospitals are doing that. But the issue is you can't just collect the data and then say, okay, well, good for us, we now have data, and leave it and never look at it. Like you have to analyze it, see where there are disparities, and then the next step is to actually address them.
Okay. Thank you for that. The next question is for you, Dr. Cavelli. How can we help those seeking surgery address their fears about the process and reassure them that their private medical information will be protected? Because we know that's an issue for people. They're always wondering what's going to happen with their information.
When they're having surgery.
Yeah.
Okay. So I mean, surgery, like any medical treatment, is very scary. And thankfully, there's organizations like the Olive Branch of Hope, and Dr. Lofters has put together an amazing website called Every Breast Counts. And these are specific to Black women with breast cancer. And so these are some sites where you can get some information that feels more culturally relevant than the black and white. Quite honestly, this is what my clinic has, and it's terrible. It's a black and white photocopied sheet of a breast with an X on it, and to try and describe what's going to happen at surgery. Talking to family and friends can be very useful. Talking to people who've been through the experience before can be very useful, but can also be very scary because not everybody's experience is going to be the same. With regards to health information, I would say I'm not quite sure I'm understanding the question. I know with research, there's often a question about health information and how it's protected. And there are a number of steps that we go through de-identifying patients or participants in studies so that their health information isn't connected to the research. But with regards to surgery, patients have to be identified when they come into the surgical suite. Like every patient in the hospital wears a band, and that's to make sure we're operating on the right person at the right time. No, and I don't mean that facetiously, right? So they can't quite be de-identified from their health information at the time of
But
surgery.
there's also, I guess to clarify, a general fear of even doing the surgery. Like there's an issue of, no, I don't need to do surgery. I'll be like, there's a hesitancy just to even go through that process. So once they've agreed and they get there, it's a little bit easier, but it's getting them there sometimes. And this is sometimes when you have an issue with cancer spreading because they're like, no, I don't want to, remove a tumor. I don't want to do those things. Like there is a real fear for some people to go through any type of invasive surgery for some of them.
For sure. Absolutely. And I think some of it is taking the time to try and understand where those fears are rooted.
Yeah.
And surgery's scary. Surgery's scary for everyone, no matter what we're doing it for. But really trying to make sure they have the supports there. It doesn't mean bringing somebody else to the appointment. I offer my patients who are reluctant to undergo surgery other opinions with other surgeons, because maybe I say something one way and it doesn't quite make sense, and somebody else says it a different way that is makes more sense, is more reassuring. I also sometimes have them talk to the other healthcare providers for cancer, that's medical and radiation oncology, just so they can see what are all the options, where does surgery fit into this piece, and then often engaging their family physician if they have one, which unfortunately not all patients do, because the family physician often has that long-standing relationship, whereas you've just walked into a room, I'm just a name, and I'm telling you that I'm going to do this to your body, which is, and then giving people time.
Yeah, and that's really helpful because it's getting them to that place I find is the hardest part. And it's that trust and going to the family physicians and people you trust to help you walk through this process. So thank you for that. So Dr. Lofters, I do want to ask about incorporating a health equity lens, and why is this important for our healthcare system in Canada?
Yeah, so I think what I will now call old school approach was just treat everybody the same, make a system that works for everybody, and then your problems will be solved. We have universal health care, so we're all good. But I think all of us have witnessed, whether through, personal experience, friends, family, that's not the way that it works in Canada. I think we often wanted to hide behind, we're very polite and we're very nice in Canada, so things must be fine. We're not like the US. But in actuality, when we do have instances of collecting race-based data, which we've seen in recent years in policing, in education, the disparities are here. So I think if we want to really create a system that works for everyone, that means that you've got to focus on those who have been left behind by the system. It doesn't mean focusing on kind of like the mainstream and expecting everybody else to catch up. It doesn't work that way, and it hasn't. We've had hundreds of years, literally, in Canada of injustices. So my viewpoint really is it's an idea, and this is not my term, but it's idea of centering on the margins. So we often talk about people who are marginalized. So then let's center our attention there. And if we build a system that works for people who are marginalized, everybody else, they will be fine.
Exactly. Thank you for sharing that. And for you, Dr. Danielle, can you talk about the discovery you made about triple negative breast cancer and the kind of research that your lab is doing to ensure that cancer treatment is more effective for Black women?
Oh boy. Okay. Small question. So I guess what I didn't say is I started doing triple negative breast cancer research, or I should say I started getting interested in 2008 when I attended a annual American Association for Cancer Research, or AACR conference. And it was at that conference I heard a breast oncologist, Dr. Lisa Newman, talking about triple negative breast cancer and how this subtype was most prevalent in Black women. And she was collaborating with physicians in West Africa, specifically in Ghana. And I think she was teaching them how to perform breast surgeries. And she had this unusually high number of women coming in with this triple negative breast cancer subtype, which by definition is triple negative. They were not expressing any of the three classical biomarkers: estrogen receptor, progesterone receptor, or HER2 receptor. And therefore, they couldn't be treated with any of the traditional drugs for breast cancer, tamoxifen or Herceptin. And so she's saying this, and I'm at the conference like, I've never heard of this type of cancer, and why is it killing more Black women? So of course I immediately went back to my hotel room and Googled it and started reading upon it. And then I wondered, is this also happening in the Caribbean? So that's literally how I got interested in 2008. My next sabbatical from research, or from teaching, I should say, to do research, was in 2011. So in 2010, I submitted a proposal to take a leave of absence to go to the Caribbean and start working on this project. So I started in 2011 working on it. And over the past decade or so, we've basically been collaborating with researchers and clinicians in Nigeria, Barbados, and Jamaica. We analyzed tissues from Nigerian and Barbadian. We haven't analyzed Jamaican tissues as yet. And we found that the gene that I discovered, Kaizo, is highly expressed in women of African ancestry in Nigeria and Barbados, and less expressed in African American and white women. And that high expression actually correlates with poor survival and poor outcomes. So we think this high expression of Kaizo is contributing to the metastatic and aggressive nature of these tumors. Because in mouse models, because my lab, as I said, is a fundamental research lab, we also use mouse models. And in mouse models, when we remove Kaizo from triple negative breast cancer cells, those cells do not spread to the lungs or liver in mice, suggesting that the overexpression of Kaizo is causing the spread to lungs and liver, at least in mice. When we remove Kaizo, it's no longer spreading, which will naturally increase the survival of the mice and the humans if we could develop a drug to do that. So
Wow, that's such important work that all of you are doing, but specifically your research is really essential. Thank you for sharing that. And how are we doing for time? Because I do have a couple more questions, and this will be for any of you can comment on this. So we have now recently heard in the news that people are being diagnosed with later stages, right? It's not stage 1, it's not stage 2, it's stage 4, which is really unfortunate because at that point the cancer can metastasize. What can we do as a community to lower our risk of getting these late diagnoses? Because I know we have to sometimes be our own advocate, right, when it comes to the healthcare system. But insights from each of you would be helpful if you want to comment.
So maybe I can comment as a family physician, because I think there was an article in the CBC, I think just in the last couple of days, and there was a Black woman talking about being diagnosed at stage 4 for her breast cancer, and how she had no family doctor. And she was trying to get into walk-in clinics, trying to get into different sites, and was unable to do so. So because of the COVID pandemic, there have been a few things that have happened. Screening was paused for a very long time. So there's now a huge backlog of screening mammograms. And screening mammograms, we know, is one way to catch a cancer before you're able to detect it at your own, or for physician to detect it by exam. So that's one issue. And then because a lot of physicians and nurses and other staff have really been burnt out by the pandemic, you've got more family doctors who are retiring early. You've got a lot of recent medical school grads who don't want to go into family medicine. And you've got just a harder time for people to be able to get in to see a family doctor. So those are like very large system issues that the government really needs to tackle. But what I can say that for individuals, like what we always say is to be breast aware. So you really need to know your body and to be comfortable with your body, so that and know what your body feels like in the course of a month, because it will fluctuate if you're menstruating, so that when there is a change, you're able to recognize it. I think a common thing that is across many different cultures is when a problem is suspected or recognized, is there is a fear to address it. So I know I have had family members and friends of family who know something is wrong, but don't want to deal with it, or don't want to say the word cancer because they worry that saying it would speak it into existence. Or, you know, my life is too hectic right now, I couldn't handle a cancer diagnosis, so I'm not going to address it. But I understand the sentiment, but none of those things change what would be happening inside your body. And I think that's the key, is that early detection can make such a difference. Breast cancer actually is one of the most common cancers in Canada, but the survival is actually in general pretty good, because it tends to be diagnosed earlier now than other cancers like lung cancer, for example. So if you're diagnosed early, and I mean, Andrea can speak to this much more, you have a much better chance of living a full, long, and healthy life. So I think it's for people to really understand it's not a death sentence. So if you find something that might mean you have to go to a walk-in clinic if you don't have a family doctor, it might mean you have to go to an emergency room, unfortunately, but it does mean ignoring it won't make it go away.
Right. Thank you for those insights. Do you want to add, Dr.
Yeah,
Kelly?
I agree with everything Dr. Loftus said, and I want to add a little bit to that. Unfortunately, I didn't see that article, but I have not one, but multiple patients that sound like that article. I would say a few things. I agree the screening has been on pause, but what I tend to see very challenging cases, and I don't know why, that's just what gets sent to me.
It's probably intentionally sent to you.
I think often they are, but that's okay. I'm actually very happy to help these women when I can. But young women, and I don't know, dare I say it on camera, Dr. Loftus, but our breast cancer screening starts at 50, unless you're in the high-risk screening program. But the problem with that is the high-risk screening program, to be eligible, requires you to know your family history.
That's right.
And if you don't know your family history or your family isn't comfortable talking about the history, you might not know that you're from a high risk family and you might not be part of the high risk screening,
Yeah.
which means you'd be eligible to be screened earlier, more frequently, and with more sensitive tools. So all of things that help you get diagnosed at a different time. And so having these conversations, which families don't want to have, my family doesn't want to have, nobody does, but knowing your family history is a big piece of getting into that program. The other thing is that we know, and this is the US data, remember, is that breast cancer in Black women tends to have an earlier age of onset. Again, and that's all comers. What does that mean for our women of Canada who are Black? Like, is it different based on our variability in our population and our immigration status and where people have emigrated from? I don't know the answer to that. But what I do tell my patients, like if they're younger and they're Black and they feel something, we're getting you imaging, right? And this isn't true just for breast cancer. There's other cancers that I won't go into for other patient populations where sometimes screening might need to be at a different age. We are not there yet in Ontario, but maybe there need to be variable screening guidelines based on people's race and ethnicity. Right. The third thing I would say is, yes, if you feel something, sometimes it means a 9-hour wait and emerge, which is terrible and awful. And I know it is. And sometimes it means being your own advocate, which I know is very frustrating when you already feel like you're not being seen by the system and you don't have 9 hours to give up and you don't have the time or patience or strength or whatever word you want to use to fight with 3 physicians to try and get breast imaging. And I'm sorry that it has to be that way sometimes, but I would say again, yes, be your own advocate. If you're worried that there's something different in your body, you know your body best. And guess what? If it's a cyst, great. We all sleep better at night.
That's right. Those are some good takeaways. Did you want to add, Dr. Danielle?
Yeah, I totally agree about the policy and the age for screening. It's something that we need to tackle and maybe advocate more for a change in policy or just for some research to be conducted on this in Canada, since the argument will come back that we're using American data and it's different. So that's something we can write a grant for. But also I would say definitely I was blessing Lassie Parkabong, my former PhD student was here, because we always gave talks and Blessing talked about TLC. And I've been here going, what does the C stand for? But she said, every woman should be giving their breast lots of TLC. Tender loving care, but it was touch, look, and I can't remember what the C is. Does anyone remember what the C stood for? But anyway, she said, you need to give your breast some TLC, and everyone that's in a relationship, caress, maybe touch, look, caress. I can't remember. Everyone that's in a relationship, your partner should also be really well acquainted with the feel and shape of your breast. And I remember after giving one of these talks, one of our male students at the university told his parents about this, and she was in Nigeria at the time with them, and she told them yes, and she turned to the father and she said, you should know what your wife's breasts feel and look like on a regular basis if you're in a loving relationship. And a couple of months later, he found a lump in his wife's breast.
Oh, wow.
Right. And so they talk about that all the time and credit that talk that Blessing gave and, her admonition to our friend's dad that he should know what his wife breast feels like. And he took it seriously and he did it. And he's the one that found her lump. And I'm a breast cancer survivor myself, and I found my lump. And it's because I knew exactly where all of my lumps and bumps and cysts were. And I'm like, that's not one of my normal lumps and bumps. And I immediately called the doctor. And yes, I was terrified. I didn't want to call and go, but at the same time, I knew that if I didn't, it could be too late. And so it's better to be early and scared and get the treatment than to be too late and be scared because you really now have very little opportunity to survive, right? At least early and scared means you've got a lot more chances and opportunities of survival.
Wow. And thank you for sharing your story. Now, I do want to open up in the interest of time to any of you that may have some questions for the panelists. If not, I do have some wrap-up questions. June?
for Dr. Farley.
Do you want the mic? Yeah, so they can hear it fine.
Okay, so we were talking about hesitancy when it goes to surgery. And I know hesitancy when you're speaking to oncologists and you don't understand the lingo and you don't know what they're talking about. But when you're talking about the surgery, I wish that they would have explained what happens after the surgery to your body, because we are predisposed to having keloids or they cut your body, what happens with your lymphatic system, you're gonna have, so what is the aftercare that you need to look towards after you have surgery? Maybe that is why some people, first of all, they don't want to talk about the cancer, but then they really don't want to talk about the surgery because what happens after?
That's a great point. Thank you for sharing. I know we intentionally do teaching around aftercare, but I am very fortunate and I recognize this. I'm in a big downtown hospital that has lots of resources. I have a nurse that's dedicated to my breast cancer patients. And I know that again, when we think about access, that's not going to be universally true. So if you're seeing a surgeon in a smaller community, they may not have that nursing that sits there and does the hour teaching with you, or is a phone number that you can call after. And again, these are things that I don't know how we make more equitable, because those go back to the provincial level. Like the reason I have this nurse is that the hospital I'm at is willing to fund it. And that might not be in the funding envelope or the money that another smaller hospital has. And so how do we address those inequities? It's interesting that you bring up keloids. That is something I absolutely talk to my patients about. I specifically look if they've had a keloid at the biopsy site or other parts of their body, because there are strategies that we can take at the time of surgery and after to prevent keloid formation. Interesting, Elaf, who is in very much an integral part of the research that we do. She couldn't be with us today. She recently shared with me that the statistics around keloids come from one paper from like very, very, very long time ago, which was poorly done. So even keloid statistics, we don't really know what they are. Yeah.
Wow, and thank you for your question. Okay, all right. So we will take a question from the chat because we do have folks on Zoom, tuning in. I'll go come at the mic.
So I'll just read it. It says, that's true. I had my lumpectomy /lymph/sentinel nodes taken as well last September 9th, but until now, I have not received the result. I called my surgeon and did not get it yet. My doctor is at Mount Sinai. He says it's understaffed at the lab. I'm so worried.
I was going to say, is this my patient? No. So no, and this isn't unique just to Mount Sinai. I can speak to Mount Sinai and I can speak to UHN because I work at both of them. The healthcare crisis that you're hearing about is real, unfortunately. It's not just family physicians, lab technicians. So literally the people, just to give you an idea, when I take out a cancer, that cancer goes to the lab. It gets what we call processed and put in a freezer and cut up and made into slides and looked at under the microscope. And a lot of that is done by what we call path lab technicians. And at least in those two centers, there's a significant shortage. Lots of people have left during the pandemic, and it is trickling down and our patients are feeling it. These delays in healthcare aren't just getting in to see your family physician. Unfortunately, it's something like that, waiting for your pathology results. I know as physicians, I work very closely with the pathologists. We're advocating to get the results because it is determining your next step in treatment. To that person who's online, I can say that your next step in treatment will not happen until you're healed from surgery. So we usually don't start it until 6 weeks, but we're getting to the 6 weeks mark. It's very nerve-wracking though, to be sitting there for 6 weeks without your pathology results.
All right, thank you for those insights. Does anyone else in the audience have questions? And then we'll turn to the chat. Is there a chat question? Check in.
Thanks. 8 of his patients still waiting for the pathologist. 8. Wow.
Wow, that's unfortunate. It's a huge gap with our healthcare system. Does anyone else here in the audience have a question? Okay.
Thank you. Thank you to the doctors. Are there any measures being put in place to support newcomer or undocumented persons who are locked out of the healthcare system?
I know that so typically when people arrive, there's a 3-month wait before you're able to get OHIP. And I know that in some cases that becomes much longer than 3 months. There certainly is a lot of advocacy happening right now to push the government to get rid of that 3-month wait time and give people healthcare right away for obvious reasons. Where that will go, I don't know, but I know that there's a physician group that's advocating for that. Physicians and other healthcare professionals and other just health advocates who are pushing the government to get rid of that 3-month wait period. There are certain sites in the GTA, at least that I can speak of, that do provide care to people who don't have OHIP for whatever reason, whether they are people who are undocumented or have lost OHIP coverage, or who are applying for refugee status but haven't yet received it. So many of the community health centers will do that. At Women's College Hospital, there's a clinic called Crossroads, which is specifically for refugee health. I think that in Scarborough, there's a clinic that does that. So there are a few sites, but it takes work to find those. So there is a push right now to get rid of that 3-month wait period.
The other thing that happened during COVID was one of the positives, I guess, of COVID is if you came into the hospital, so through an emergency basis, not something necessarily elective, without healthcare, you were automatically covered. So the government was giving the hospitals money to reimburse for the coverages, as opposed to the hospital sending people bills. So that's actually been nice for patients, because I have many patients come in worried. What do you mean I do general surgery on call. So I'll see patients come in and they say, I can't go to the operating room. I can't afford it. And thankfully that has been eliminated. Yeah. I don't know how long that's going to.
It's still ongoing.
It's still ongoing right now. I don't know how long the government's going to do it for. And I don't know how people know. I don't think it's widely advertised. Yeah.
Wow. And it's important that we share information, because if we don't know, it could cost your life, right? Does anyone else in the audience have questions? So I want to make sure we give everybody an opportunity to ask a question to the doctors. Okay. Now I do have, okay, sure.
Hello. Thank you, ladies. My question is, my aunt, who is 92, she's a breast cancer survivor, but she also has lymphedema now in her arm, and her right arm is so swollen that it's hard for her to even lift it up. And then she was complaining about bleeding. So the doctor figures that the cancer may have come back. And when I keep advocating for her and my other cousins as well, because they were sort of being dismissive about her, their age. And I'm like, no, I want something done. She's still alive. And so we're getting an ultrasound, but what happens? Because I feel like, why do we have to push so hard for us to even be listened to or to be taken seriously? I find that that's really hard to even take, because even if no matter what someone's age is or their, whether they have or their wealth or anything, I think I just feel like it's not always taken as seriously. I don't know I know it's not a question, but it just hurts my heart with that.
Yeah. So I'll comment on more broadly, because I think this also ties into the idea of having breast cancer screening before age 50, because it's not that you can't have it. Like a woman who is 40 can have a mammogram. What is supposed to happen is something called shared decision making. So I think that ties into the example you gave, that there should be a process of shared decision making, which is looking at what are the risks of treatment of anything that could happen to your aunt, what are the benefits of it, looking at quality of life, like what's her perspective, what's the family perspective, and the physician's supposed to help the family and the person then come to a decision of how they want to proceed, as opposed to saying, I think that because she's 92, it's that we should do this. Or saying, I think because you're 40, you're too young for a mammogram, so I'm not going to order it. So what we as healthcare providers are supposed to do is that shared decision-making process where we give you the information, but that really you're supposed to be empowered as the patient to make a reasonable choice about your own healthcare and how you'd like to proceed. And I'll just say that often I think we don't do that. And I think people are rushing and they want to go on to the next person. And I think it does come back to the idea of advocating and saying, no, like if a decision is going to be made, I need to know what are the risks, what are the benefits, why is it, what's the evidence, why is this particular treatment path being chosen or not chosen? And sometimes that does mean getting assertive, but really as a patient, it is your right.
I would like to second that. I think sometimes we fall into a bit of ageism in medicine, and someone might say, oh, well, she's 92, no one's going to treat her anyways. But if you don't know what it is that we need to treat, we don't know how to treat it and what the risks of that treatment might be. I mean, I've done very big surgeries on 95-year-olds because it's not about the age, it's about the person who's sitting in front of you, what makes sense for that person, what makes sense for the family and the quality of life. And so I agree with Dr. Lofters. Unfortunately, it does mean sometimes advocating for yourself. And we, like I said, we see it with ageism, and we also, obviously, there's an intersectionality sometimes between age and race, and it's unfortunate, but yes, advocate, absolutely.
So I would like to add to that. Advocacy, especially in a small hospital, especially being someone of color, and you want the best care, and you don't necessarily want to go to the front of the line because you understand the way the system is. And for example, I've had breast cancer, triple negative, twice, and recently just got diagnosed. And I spoke to my oncologist, and he just looked at me and he just was really upset because he did his best. And he said he was devastated, but the steps after that was to get a bone scan and a CAT scan. And it was a Thursday before Thanksgiving. And he said, I'm going to rush this for you. Being at a hospital, at a suburban hospital, which is the SHN network, Scarborough Health Network, you don't know how great their equipment is. You want to advocate for yourself, maybe go downtown depending on whatever. But now you're telling me that pathology takes 6 weeks, even downtown. So you don't know anymore what is happening. But for me, he looked at me and he said, if you can get in tomorrow, go upstairs and ask them. And he said, I'm going to try to get you in for next week. I'm going to push. I'm going to ask my manager. So there are routes you can go, depending on how serious things are for you. So I went up and I went to radiology and I said, can I get in for today? And the lady looked at me like if I was, I was an alien. And I'm like, and I really did feel bad because, you're in a room with people, you want them to get their care. You don't want to push ahead of the line. And she goes, tell your oncologist, she said, in fact, let me call down and tell them who to call. My husband was waiting for me. And so I just loitered in the hall and looked to see where the CAT scan and the bone scan was. And people came out, I asked them, they're like, I'm busy, right? Maybe, tomorrow I'm on my own, next week it's busy. And I said, please, my oncologist asked me. And she said, okay. She went in, after about 40 minutes, she got me in, and the bone scan person, got me in as well. And when I didn't meet with my oncologist who, let me know that the cancer had metastasized to my lungs, and he said to me, he goes, how did you do it? And I said, I just stood there and I asked, right? I wasn't rude. I was respectful. So you must advocate for yourself. Even little things like when we were talking about neuropathy right now, the hospitals, it may not be a thing of what the color of your skin is, but the hospitals don't give you the gloves to stop the neuropathy because they're too busy. And some people get it, some people don't. But when you go in, you ask for those gloves so that you don't have the pins and needles in your hands, and you're not going to be worried about if you're going to live with this for the rest of your life, because chemo is very hard on the body, and some bodies can recover, some bodies can't, right? So it is no one can say this as much as how important it is the education and asking the questions and, you know, just being humble but asking the questions is so important to advocate for yourself, for your 92-year-old grandmother. Her life is important, right? And as long as people see that you're serious and that you value something, they will. They're good. Thank you.
Thank you for sharing your story. All right, so Ms. Winsome, who, as you know, is a co-founder of the Olive Branch, did leave a question because she had to leave. And I'm going to paraphrase her question. So she's someone who is talking about, just in general, for people who have went through chemo, radiation, say it was decades ago, then they're starting to experience things like itching in their breasts or other symptoms. Can you comment on whether or not there's some long-term effects of radiation and chemo and things that people should look out for?
So this is my disclaimer. I do not want to scare everybody who's online. I treat something called sarcomas, which are very, very rare cancers. Unfortunately, there is something called a radiation-induced sarcoma. It's very rare. It's like 1 in 5,000. So most people don't get it, but people can get it. It can happen as short as 6 months, but usually the average is 10 years after your radiation. And it happens in the radiation field. So if you have tattoos, the little dots that look like blue freckles, tends to happen between that. It often starts like a bruise. So what I see is women say, oh, I banged myself, and then it didn't really go away, and then it got bigger and bigger. That's how it starts. Now I recognize that a bruise doesn't look the same on everybody, right? So if you were dark skinned, you might not see a little, what we would consider a pink dot on someone who's lighter skinned. So if you've had radiation and there's changes in your breast that you're worried about, go get them looked at. I don't want everyone at home thinking that they're sitting there and have this terrible cancer, but do go see somebody. Absolutely.
Thank you for that. And so I do have some wrap-up questions for the panelists here, and it's about impact and legacy. So the question for each of you is, what type of impact do you hope to make from the work you're doing? And what type of legacy would you like to leave within the science and healthcare sector? It is a big question, but I'll give you some time to process.
I mean, I think it comes down to wanting to do good and meaningful work, right? I think in research and healthcare, it is easy to get disillusioned and feel like you've done tons of stuff and it hasn't actually made a difference. But I honestly think events like this make much more of an impact than writing a paper in a journal that nobody reads. I think if real life, everyday people can become more educated, become more aware, learn more, be inspired to go and learn more, to ask an additional question at the doctor, to talk to family and friends. To me, I think that's impact, is just, how can we just educate and raise awareness. Working with the Olive Branch of Hope, has been amazing. I don't know how Leela and the team does so much amazing work. This is part of our job, but this is, volunteer work. And I think just seeing events like this that happen over and over and over again, where people are learning and learning, becoming more aware and becoming advocates, both for themselves and for the community. To me, I think that's the real impact. And I would say probably the same for legacy. I just want to be known for having done good work.
Awesome. Thank you. Dr. Kelly?
I would echo a lot of that. I'm very thankful to have been embraced by Leela and brought in to be part of this work. I think at the end of the day, what I would love to know is, your patients don't often tell you what they're really thinking or how they really feel after they leave. But what I would like to know, it's a little bit of idealism, but that the patients in Ontario and in Canada, when they walk into their physician, they don't feel like they were treated differently. Like they feel like they had the same access to resources, they got the same information, that their care was the best care that they could receive for the person sitting in front of them. And I think we're not there. And it's not just me and it's not just us. It takes an entire community and I think an entire nation to get there. But I would love to see that that is where healthcare goes. And Dr. Loftus mentioned it, we have universal healthcare and it's been, everything else has been kind of swept under the rug. So we have a universal healthcare, but we don't have universal healthcare, right? We have universal coverage, but all the things to get you to that healthcare, those can look very different.
Yes, thank you. And for you, Dr. Daniel?
Oh, boy. Yeah, definitely universal healthcare and also just all of our physicians being like what I consider the original non-racist ones that did the Tuskegee, et cetera. But, you know, like many physicians hundreds of years ago genuinely cared for their patients. Many of them were researchers as well, right? They weren't just treating their patients. They were literally in their little kitchens making concoctions. And I would love all physicians in Canada to have that recognition of one, the value of research to their practice, because right now many physicians don't value researchers and what we do. So I would love all physicians to do that and all physicians to genuinely care and value each individual patient as a patient, because again, that is not happening. I was blessed with a fantastic family physician, Dr. Tamara Packard. She's going to yell at me for saying her name, but she was one of the most amazing physicians that I had. I had a fantastic healthcare team personally in Hamilton. And for me, that made a difference to my mental health going through the whole process. And knowing that, and then talking to others who haven't had that experience, I realized how that can also impact your outcomes, because you're not as positive if your healthcare team isn't as positive or as encouraging. So I would love to see that. And I would love to see hundreds of Black cancer researchers and hundreds of Black clinicians, you know, just 10 years from now. I'm not waiting 30 years. 10 years from now, whether we have to import them from the Caribbean or Africa, I don't care. I just want to see hundreds in the next decade, because Canada is a huge, physically large country, but we're small in population and we have so much more capacity. And as you said, with all of the physicians and healthcare providers that pretty much retired because they were overworked and overburdened and underappreciated during the pandemic, like we can't really blame them, right? Some of them literally are now struggling with their own mental health issues and they had to retire because they couldn't do it anymore. So I would just love an appreciation for how we're all part of an ecosystem on planet Earth, and we all, everything that each of us does impacts someone else. And I think we've lost track of that. And, you know, like being our own brothers and sisters keeper.
Yes, that's really important. And thank you to each of you. And this does conclude our conversation. So I hope all of you found it insightful, impactful. Tell others about this conversation. Tell everyone about the work that the Olive Branch of Hope is doing. How can folks stay in touch with each of you for those who may want to reach out or connect? If you wanted to share the best way to stay connected.
So on that table over there, I think there are handouts that are related to the Every Breast Counts website that is out of my institution at Women's College Hospital. I'll give a plug that on October 27th, we're actually hosting at Women's College Hospital a breast and cervical cancer screening day. So for people who want to get their mammograms done, and we are definitely open for people who are under 50, people who want to get their Pap test done, we're providing, if people need it, transportation and a bit of a goodie bag. So there's information about that there. Happening at my institution. And then I think information about Andrea's study is on that table as well. If you want to speak a little bit about that, Andrea.
Yeah, and it's not my study, it's our study. I was just
made Andrea do most of the work.
I just wrote the paper that got us the money for our study. So we are doing a study, as you heard, we don't have race-based data in Canada, but we all truly believe and know from our personal experiences that inequities do exist. So we're doing a study trying to identify the inequities in care for Black women with breast cancer across Canada. It's a qualitative study, meaning our participants engage in an interview to try to understand what your experiences are, where do the challenges and inequities occur. And after we do this, we take patients are de-identified, so you will not be connected to the findings. But we do take these findings and we're trying to develop actionable goals or tools. And that we're going to try to do across Canada with larger partners. So Canadian Cancer Society, be it what used to be CCO or Ontario Health, and how do we try to address some of these inequities? So that's the study that we're doing. That flyer is on the table. Maya is our contact person on there. And you don't have to be part of the study. If you want to reach out to me, you can still do it through that.
Awesome. Thank you. Dr. Daniel?
There's a postcard as well about our Think Beyond Love Pink workshops on the table here.
I actually
And
have
you
one
can-
here.
Yep, there we go. And so my information is on that. I have more updated cards in my car, which I will get right after this event. But also I'm a professor at McMaster University, so it's pretty easy to just Google Juliet Daniel McMaster University and you'll find my email.
Awesome. And to those of you who tuned us online, thank you for joining. Thank you for your questions. We hope you found this insightful. And I do want to pass it over to the fabulous Miss Leela Springer to say a vote of thanks.
Thank you, Ms. Stacy, for doing such a wonderful job. Thanks to these three wonderful physicians, researchers and physicians and researchers. That's Aisha is wearing both hats there. And thank you so much, Dr. Covelli, for the work that you are doing as well. And I'm glad that we were able to allow you to be a part of this because, when we think of it, it's not all Black doctors looking after us. So we have to be able to embrace everybody. And I really thank you for being here. It's been encouraging for me. It's been insightful for me. And I hope it has been insightful for you as well. Fortunately, I lost my voice yesterday. That may be good. And it may not be so good. But I really do appreciate all of you that are here filling up these chairs today. Appreciate you so very, very much. Thank you, Dior, for sponsoring the event. Really appreciate that as well. And I hope we can do this again. I know how hard it is to get the three of you together. It's been so hard, back and forth, but I can't make this day. I can make that day. I can't make this day. Oh yeah, Tuesday's day, the other weekend. And it's been so difficult, but we got it done. And that makes me feel so very, very good. And I do what I do because of you. I do what I do because I love you so much. And yes, I've been doing this for 2 decades, over 2 decades. And I do it voluntarily. If you ask me, it's not been easy. It's been extremely difficult. But it's important for my grandchildren. I've got 4 granddaughters that are coming up. And I want to make sure that they have the best care that they can ever get if they ever hear of a diagnosis of breast cancer. Because for the rest of their lives, they are going to hear when they go to their doctor, your grandmother had breast cancer. They can't get away from that. And so I do it for them and I do it for you. And I really appreciate you. I do. I appreciate you so very, very much for being here today. You didn't have to come, but you did. And I hope that when we mingle afterwards, each one of you will let these doctors know how much you appreciate them. Please, please let them know how much you appreciate them. And if you have friends or relatives that are not documented, but would like to get a mammogram, please, Dr. Lofters has mentioned that they do those that are undocumented. Nobody asks any questions. They just want to make sure that we are healthy. And just let them know so that they can get tested. And thank you to our sound people, to Mookie and his team. Thank you so very much for always doing such a marvelous job. Appreciate all of you. Thank you, Stacy. You were great. Stacy was the first one on the job when we did our Think Beyond Love thing. She was crisscrossing across Toronto, trying to get interviews and all these. This is a wonderful program. It's a wonderful. And doing an excellent job. Thank you so much. All we lack to do any more of these, it's funding. That's what we don't have.
It's
mean,
coming.
we-
It's
We
coming.
haven't been any,
It's
we haven't
coming.
been any further because we never had the money to do the things that we really want to do. But we're here.
It's coming,
Thank you.
Leela. It's
And thanks to
coming.
my pastor that she came in late, but she came. And she doesn't want me to mention her. But this is my pastor's wife, Bridget James. And she came out today to join us. Appreciate all of you. Thank you all so very much.
Thank you. Thank you to everyone again for joining us. So this does conclude the program. So feel free to mingle and network, talk to the doctors if you like, or if you need to leave, that's fine as well. So it's a pleasure being your host. I'm Stacey Ann Berry. You can connect with me on LinkedIn. And again, it was a pleasure and it's an honor to serve the Olive Branch of Hope.
Lord, I'll take your hand.